Good afternoon, everyone. Welcome to the ASPPH hosted webinar on the latest supplemental issue of Public Health Reports, the official journal of the Office of the U.S. Surgeon General and U.S. Public Health Service. My name is Jared Stokes, and I would like to welcome you to the webinar on behalf of the PHR team, including our Editor-in-Chief, Dr. Hazel Dean, and Managing Editor, Dr. Andrei Kuzmichev. Published since 1878, Public Health Reports is dedicated to publishing original research, reviews, and commentaries in the areas of public health practice and methodology, public health law, and teaching at schools and programs of public health. Public Health Reports' most recent supplemental issue focuses on using public health policy to reduce the morbidity, mortality, and incidence of HIV, viral hepatitis, sexually transmitted diseases, and tuberculosis, and was sponsored by the Centers for Disease Control and Prevention's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. On behalf of the journal, welcome. Before we begin, a few items of note. This and all ASPPH Presents webinars are recorded and available for viewing on the ASPPH website. You can ask questions in writing at any time during the session by clicking on the Q&A button at the bottom of your screen. We will hold questions until all the presentations are finished. On behalf of the U.S. Surgeon General, Vice Admiral Jerome Adams, I want to welcome our moderator and panelists for joining us today, and I want to thank them as well. It is my pleasure to introduce Ms. Sarah Ziegler. Sarah Ziegler is the Associate Director for Policy of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention. A CDC employee since 2002, Sarah has provided policy and program technical assistance and leadership to staff members and hundreds of CDC awardees in infectious and communicable disease programs. Sarah provided policy leadership in CDC's 2015 Ebola response, and in 2016, during the Zika response, Sarah led the development of the Zika Action Plan Summit. And most recently, Sarah served as the senior advisor for strategy and program implementation for the Chief Health Equity Officer for the COVID-19 response. Without further ado, I would like to turn this presentation over to Sarah.
Thank you, Jared, for the introduction, and thank you all for joining us today. As Jared noted, released earlier this month, a special supplement of Public Health Reports was published highlighting policy research and implementation as essential components to address complex, multi-sectoral factors that influence the population-level morbidity, mortality, and health disparities of HIV, viral hepatitis, STDs, and tuberculosis. The special supplement was co-sponsored by CDC's National Center for HIV/AIDS, Hepatitis, STD, and TB Prevention. Laws, regulations, and other standardized procedures and practices can influence institutional and individual behavior to improve health and advance efforts to achieve health equity. We also know that some of these policy tools were not designed to achieve health-related objectives and can have important but unintended positive or negative health effects. Systematic study of the association between policies and population health is needed for guiding development and implementation of health-promoting policy strategies that are feasible, cost-effective, impactful, and that minimize harm. Today, we will hear from two researchers who are published in this special report. They will highlight their work and underscore how policy research can have a profound impact on the lives of all Americans. I will now introduce our two presenters before they speak. First, I'd like to introduce Marcelo Vernandez Vina, a law and policy analyst at the Center for Public Health Law Research and the Beasley School of Law at Temple University. Marcelo began his public health career while completing his MPH, where he focused his master's project on assessing the Philadelphia Department of Public Health's response to CDC's Program Collaboration and Service Integration Initiative, which focused on improving disease prevention, surveillance initiatives, and improving access to health services for HIV/AIDS, STD, viral hepatitis, and tuberculosis. After completing his MPH, Marcelo was hired by the Philadelphia Department of Public Health as the Adult Viral Hepatitis Program Coordinator, where he served until he became the Program Manager for the Office of Program Collaboration and Service Integration. Marcelo's experience in public health program management led him to pursue a law degree to better understand and address the legal and policy barriers to public health program implementation. While in law school, Marcelo worked as a research assistant, teaching assistant, legal research fellow, and pro bono legal intern, and as a contributor to and the blog coordinator for the Philadelphia Inquirer Health Sense blog. Marcelo is the lead author of State Laws Governing Syringe Services Programs and Participant Syringe Possession from 2014 to 2019. Additionally, I'd like to introduce Kelly Thompson. Kelly is a policy analyst at the Public Health Management Corporation. She's responsible for managing legal research projects and policy initiatives. Kelly helps to provide a legal perspective on multidisciplinary teams developing public health law projects, which span topics from health and social equity concerns of vulnerable populations to emergency preparedness. Her favorite focus areas are intersections of criminal justice issues with public health outcomes. After graduating with a dual Bachelor of Arts in Criminal Justice and Sociology from the University of Delaware, Kelly moved to Philadelphia to earn her JD from Temple University's Beasley School of Law. Kelly is the lead author of Using Mixed Methods and Multidisciplinary Research to Strengthen Policy Assessments, focusing on populations at high risk for sexually transmitted diseases. Just as a reminder, we were going to hold questions until after Marcelo and Kelly have completed their presentations. And with that, I will turn it over to Marcelo for the first presentation. Thank you.
Okay. Hi. Okay, so I think you all can hear me now and I should be unmuted. Thank you for that introduction, Sarah, and thank you all for having me. It's honestly an honor and a pleasure to be here. As Sarah mentioned, I've done some work with NCHHSTP before in my previous public health career, so it's really exciting to be back here and speaking in this capacity. So as Sarah mentioned, I'll be talking about our paper focusing on SSP laws in all 50 states. Before I get started, I just want to thank my co-authors, Nadia, Adam, and Josh, as well as a special thanks to Professor Burris for his guidance and leadership on this project. It's not letting me advance. I'll try these. Okay, here we go. Sorry, there's a little bit of a lag. So the epidemic context of this paper is something you all should be familiar with. As you all know, HIV and viral hepatitis attributable to injection drug use is a public health priority. It has been for a very long time. And as you all know, the current status of these epidemics in some cases has stalled. The progress that has been made over so many decades has started to slow down, but there are also increases in certain hotspots, especially for HIV, and then for hepatitis C, we have seen major increases in the number of cases. So the programmatic context is another one that you all should be familiar with or are probably very familiar with. So SSPs, as you all know, just based on their name, they provide people who inject drugs with sterile equipment and syringe disposal services, but they also do a lot more. So SSPs can provide or link people who inject drugs to services including vaccination, treatment, testing, overdose prevention, and doing things like connecting people to housing and so many other supportive services. And we'll get into some more of that when we talk about COVID in some of the questions, I'm sure, because that's going to come up. So in terms of the evidence base, this is something that we didn't look at ourselves, but it was the foundation to our background. SSPs have been shown to be safe and effective and cost-effective, especially in reducing HIV and hepatitis C transmission. And as a result, they've been a major part of the national HIV/AIDS strategy for a very long time. So the legal context for this. So SSP coverage in the US has remained incomplete and uneven from the legal perspective, but law has always been seen as a major factor in the availability of SSPs. So this last bullet is one that I want to focus on and maybe expand more broadly. So SSPs are not explicitly forbidden in US federal and state law. So some people have thought that SSPs are illegal due to laws around distribution and possession of drug paraphernalia or syringes. But these paraphernalia laws and distribution laws were in place before SSPs were ever devised. So that's something that I want to expand more broadly to public health in general. A lot of folks tend to think that there are legal barriers in place when they may not actually be there. So this is where I would encourage public health practitioners to reach out to people who are in the public health law space, people like myself, people who work at the center where I work, or other people out there who are doing public health law research, just to get a better understanding of the legal context in which public health works, and to not limit the innovative public health work that happens just because people tend to think that certain things are illegal or off the table. These options are available, and doing that type of analysis can really facilitate the advancement of public health. So that leads us to the objective of this paper. The objective of the study was to map state laws governing SSPs and identifying their changes from 2014 to 2019 in provisions that may impair the effective operation or use of SSPs. So something that I'm excited to share with you all, this is not just a paper, this is a data set that is publicly available online on our website, lawatlas.org. And if you go to that website, you will be able to interact with our data and create maps for your individual use if you're interested in specific components of this project. Not to mention there are over 100 data sets related to various areas of public health where you can look for additional resources or things that are within your interest area. So now getting into the methods for this paper, so I won't dig too far into this. I really just want to give you a flavor of the type of work we do, and I'll do the same with the results. This is more just to point you in different directions of the paper, so that if you want to dig deeper, you can. So in terms of the methods that we used a scientific legal mapping procedure. So there's more information on that on our websites. We engage in activities that we call policy surveillance or legal epidemiology or legal mapping. All of those mean different things. And if you look into the resources that we have available at our center, you'll be able to learn more about how we formally and in a structured way conduct legal and policy research. So what we did is we developed a data set measuring key features of state laws and regulations governing the possession and distribution of syringes across all 50 states and DC that were in effect on August 1st, 2019. And from there, we determined the initial scope and the inclusion criteria that we wanted to use for our research. And we used the Westlaw database to do our research. So in terms of inclusion, so we included paraphernalia laws and laws that had to do with the explicit authorization or prohibition of the possession of syringes. And we excluded regulations having to do with pharmacy operations or retail sale of syringes, which is a related field, but not what we were looking at in this particular study. From there, we developed coding questions, and then we conducted research and coded. And we always have redundant researchers on all of our projects in order to ensure that we're coding in the best way possible. We also gathered information on the number of states that had operating SSPs on August 1st, 2019, and you'll see more of that in our results slide. So this is what you all have probably been waiting for. So these are the results, and just like with the methods, I'm going to give you a flavor of this, but if you want to dig in deeper, I will point you in the direction of the paper, and then feel free to reach out and we can chat through some of those details. So the big takeaway here is that of the 50 states and DC, 39 states had one or more laws in effect on August 1st, 2019 that were consistent with the legal operation of SSPs and or explicitly authorized and regulated SSPs. So that means that 39 states, in theory, would allow the operation of SSPs in that state. At the same time, SSPs were operating in 41 states and DC as of that same date, and that can be seen in the maps below. On the left, you have where SSPs are operating, and on the right, you have states where the laws are authorizing or are consistent with the legal operation of SSPs. And as you will notice, that those maps don't totally overlap. So there are some states where the law would allow for SSPs, but SSPs aren't operating. And there are other states in which the law isn't authorizing SSPs, but SSPs are in operation. And that may be due to a number of reasons, including local authorization for SSPs, which is another way in which SSPs can be authorized to operate. So some of the major takeaways from another part of our results. So 32 states explicitly authorized SSPs by law. So that has increased by 14 states since August 1, 2014, which is when we last did this analysis. So 7 states not affirmatively authorized SSPs, but they did have legal conditions that would allow for SSPs to operate. And the total number of states with at least one provision reducing legal barriers to SSPs increased by 12 since the date in 2014 where we last did this analysis. And 12 states had no legislation that would remove legal barriers or uncertainty for the operation of SSPs. So there is a lot more of that data in table 1 of our paper if you want to reference that. And we have various categories in terms of the types of laws that are in place to allow for SSPs to operate. And as you can see, some states have multiple ways in terms of like reducing barriers to SSPs. So our table 2, which is another set of results that are of interest. So there are 4 sets of additional legal requirements we looked at for the operation of SSPs. So 9 states required local government approval for SSPs to operate. 3 states required local law enforcement consultation, and 2 states required both local government approval and law enforcement consultation prior to the operation of SSPs. We'll get into what that means a little later. And 4 states required 1-for-1 exchange, meaning that for every syringe brought in, 1 syringe is given back. So for you public health folks out there, you know that the evidence suggests that you would want to distribute more syringes so that more syringes can be out in the community and into the broader networks of people who are using drugs. And the same is true for the following limitation, which is 2 states have laws that say that SSPs may not be redistributed, meaning that people who come to get syringes can't redistribute them to their extended networks. So this is table 3. So I didn't really dig into this one, but this one would be the one that would be of most interest to folks at the National Center that was mentioned and the National Center that sponsored this special issue. But for those of you who worked in HIV, STD, TB, and hepatitis like I did in the past, this table is very interesting because on the left-hand side, you have all of the additional services that could be required by law for an SSP to operate. In the center column, you have states that require that service to be provided on site. And on the right, you have states that require that service to be provided via referral. So we'll talk about the benefits and disadvantages to providing services or to writing in services into the law. But this is a pretty comprehensive, or a comprehensive list of states that have those requirements. So those of you who are interested in service integration, I would point you in the direction of table 3. And then finally, table 4. So this is a major point that I want to drive home. So just because distribution of syringes is decriminalized or allowed by law, it doesn't necessarily mean that possession of syringes is allowed. And that disconnect between distribution and possession in the law is one that can lead to problems practically in terms of the implementation of SSPs. So 33 states had 1 or more laws on August 1st, 2019 that were consistent with the legal possession of syringes by SSP participants in at least some circumstances. And 20 of the states that authorized SSPs in their laws in terms of distribution had provisions exempting SSP participants from syringe or paraphernalia possession crimes. But then the last bullet on here is an important one and a striking one. 18 states, including 7 of the states that had laws that authorize or reduce legal barriers to SSPs, had no laws that remove or reduce syringe possession-related legal jeopardy for SSP participants, meaning that there's 7 states out there that would allow for distribution of syringes, but wouldn't protect their participants if they were caught possessing syringes. So those are some disconnects in law where there could be work to be done. So these are, this is the full table 4. So if you're interested in the possession side of things, I would point you in the direction of that table to get more information there. And then, so our overall takeaways here from this paper, so 32 states had explicitly authorized SSPs as of August 1st, 2019, and 39 states overall had taken at least 1 action to address legal concerns about SSPs. So since 2014, the number of states explicitly authorizing SSPs nearly doubled. And the new states included many rural, southern, or Midwestern states that had been identified as high risk in previous publications. And 12 states still have no clear statewide legal basis for the operation of SSPs. So in terms of discussion and some major takeaways and things that I would encourage you all to take back to your groups and to discuss further. So just because there's laws in place for SSPs and for syringe distribution, it doesn't necessarily mean that there's funding attached to support those programs. So authorization does not equal funding. And coordination of the expansive services that SSPs engage in, those aren't supported through the laws either. They may be required in some instances, but there is funding isn't necessarily attached for the coordination of services just because there's a law that allows for the operation of SSPs. Local government approval is one that I showed in table 2. So on the one hand, people may think that getting community buy-in for the operation of SSPs is a valuable thing to add into the laws. But on the other hand, if you're thinking of setting up an SSP in a high-risk area or a high-need area, that may pose an additional barrier if community support is absent in that area. Things like one-for-one exchange and redistribution prohibitions are the types of limitations that really affect the practical implementation of SSPs. And it's something to consider, especially in light of some of the evidence that shows that distribution of syringes more broadly could help reduce the disease burden of some of these epidemics. And then the comprehensive service requirements was one that was really interesting to me. That was the table 3 that I pointed out earlier. On the one hand, we really do want to support comprehensive services being offered at SSPs and one-stop shops for disease services, but at the same time, writing those into law may actually create a burden to starting up an SSP, because if you think about not only doing syringe distribution, but getting HIV testing, STD testing, TB testing, et cetera, set up on site, that may be too much for a site that really needs to set up quickly. So these are things all to consider in the setup of SSPs and to really consider some of the limitations of laws and the disconnect between law and practical implementation. And of course, the last one, the inconsistencies between possession and distribution. So in conclusion, we've talked about most of these, but the real takeaway is that our study found a general trend towards the expansion of the legal bases for SSPs across jurisdictions, but 12 states still provide no legal basis for SSPs to operate, and the legality of syringe possession remains ambiguous in many places. So with that, I'll leave you with our final slide. So if you do have questions about the paper, feel free to reach out to our corresponding author, Scott Burris. If you have questions about our center in general, I would point you in the direction of Lindsay Cloud, our director. And these are some resources if you want to learn more about our methodology or some more of our data sets. You can find those at Public Health Law Research or Law Atlas. And with that, I'll hand it over to Kelly.
Good afternoon, everyone. Sorry about that. I had to get my video going there. Thank you so much to ASPPH for hosting this webinar and including me on the panel, and to Public Health Reports and NCHHSTP for the honor of including our manuscript in the latest supplemental issue, along with such other incredible submissions. As Sarah mentioned, I'm Kelly Thompson, and I work in the Research and Evaluation Group at Public Health Management Corporation, which is a large nonprofit public health institute headquartered in Philadelphia. My co-authors, Archana Bodasapalo and Sarah Hexam, also hail from PHMC. We've had the pleasure of partnering with and being supported by CDC's Division of STD Prevention on a number of collaborative projects over the past 5 years. My co-authors, Brian Kramer, Harold Chesson, and Jamie Leakleiter, are our wonderful colleagues at the division. Our co-author team has employed a mixed methods and multidisciplinary approach to exploring relationships between policy and disparities in sexually transmitted infection risk and transmission. Our manuscript reflects on what we've learned from our approach over the course of 2 specific studies of policies that may affect 2 populations at high risk for STDs: people involved in the criminal justice system and lesbian, gay, and bisexual populations. We highlight lessons that we learned and implications to inform future work and research by other stakeholders addressing complex concepts like health equity. So I'll briefly describe the central ideas that helped us shape the two studies described in our manuscript. STD rates are rising, but effective interventions continue to lag. Therefore, our primary goal for our research is to identify relationships between laws and STD risk and prevention in order to inform STD interventions. Numerous studies document the influence of social determinants of health on STDs. I imagine this audience is intimately familiar with social determinants and how they're defined and conceptualized, so I won't spend too much time here. The bottom line really is that research demonstrates the particular determinants affect STD burden, and more research is needed to understand how, and that's really where our work comes in. So laws and policies can function as social determinants in multiple ways. Laws can be implemented to directly respond to health needs, like regulations to increase or streamline insurance coverage for COVID-19 related care. But as we know, many statutes that on their face are unrelated to health will have some impact or relationship to health. Laws can be interpreted differently, over or under enforced, in ways that directly and indirectly, positively and negatively influence individual and community health. So assessments of laws, regulations, and other policies can provide important contextual information to help develop or target STD interventions, but may not be able to assess complex associations like the roles of social determinants in STD disparities. Sometimes we can study whether a policy exists or not and whether that directly impacts health, but typically their effects are much more indirect and very pervasive when they relate to health outcomes. For example, high rates of incarceration in a community can affect sexual mixing patterns and contribute to higher STD rates. Inherent in the statements on this slide is the need for multidisciplinary approaches to adequately and scientifically study these complex intersections of laws and their indirect public health outcomes. So our multidisciplinary research team included public health attorneys trained in established policy surveillance research methods like Marcelo just discussed in his presentation, and public health scientists with broad subject matter expertise. Our team members are rooted in the public and the private sectors, and we also engaged content experts in related fields to inform our research focus and enhance our analysis. By definition, mixed methods research combines quantitative and qualitative research methods to understand a research question. We found that the concurrent and coordinated design of mixed methods research can offset the weaknesses or gaps of an individual approach. For example, quantitative research can be inadequate for understanding the lived experience of a disparity, whereas qualitative research can dive into that lived experience, but may include biases and subjectivity and may not be generalizable. Marcelo already sort of expertly described the policy surveillance method, so I won't revisit the details there. We've also used the method of developing quantitative indices as a proxy to demonstrate the overall protectiveness of each jurisdiction that we studied, so the protectiveness of a particular population. We utilize qualitative research to better assess the role of laws as implemented, experienced, and perceived by our qualitative interview participants. So, sorry, I'm having a little bit of trouble with the slides progressing. There we go. So in our paper, like I said, we overviewed what we learned from two studies. Involvement with the criminal justice system and drug use have been repeatedly associated with health disparities, including an increased risk for STDs. In the first study we discussed in our manuscript, or study one, we examined state justice-related policies by conducting a policy assessment of state laws related to justice-involved populations and a qualitative sub-study of STD policies in county jails to address gaps in the policy assessment that related specifically to STD prevention. The purpose of the policy assessment was to examine state laws and regulations that are associated with several drugs that have been associated with STDs. So we focused on these variables or proxies partly because of their hypothesized relationship to increased likelihood of interaction with the criminal justice system and socioeconomic status. So the proxies we identified were drug possession sentences for people convicted of possessing particular drugs, as well as consequences of having those convictions, such as inability for public assistance and occupational licenses, employer inquiries about criminal history, and limitations on housing eligibility. We collaboratively developed a standardized protocol for collecting and coding relevant laws. The attorneys on our team applied that protocol to every state and DC. And our assessment found substantial barriers for justice-involved persons accessing health-related public benefits after incarceration, including comprehensive prohibitions from select benefits programs based on criminal history alone. Since statutes and regulations rarely directly address STD prevention, we complemented the policy assessment with an accompanying qualitative sub-study to explore our research questions that were specifically focused on STD prevention. So what we did in the qualitative study was focus on county jail policies related to STD testing, treatment, and linkage to care. So we conducted key informant interviews with jail staff, healthcare providers, and administrators in 7 counties across the country that report high prevalence of STDs across 3 of 4 major STDs. And I noted which counties we focus on in this map on the slide. So the qualitative study was designed to help us better understand those policies that may impact criminal justice populations who are in and out of jails for short stays and frequently. Because they're in and out of their communities, it suggests unique implications for themselves, for their families and their communities. And we wanted to understand how STD prevention policies in jails may impact their STD risk, and in turn the communities to which they are returning when they're re-entering after a jail stay. Evidence indicates that many county jails, although they are supposed to give health screenings, including STD testing, do not routinely enforce those protocols. So our qualitative findings did highlight that some incarcerated people may access healthcare in jails for actually the first time, but others, very alternatively, may not have access to STD treatment and testing while they're incarcerated. And as with both studies that we discussed in our manuscript, we don't dive too much into the specific findings because they are explained in much greater detail in other publications, but really we're reflecting on kind of what we learned from these studies in terms of applying a mixed methods and multidisciplinary approach to future research. So with that, I'm gonna jump right into an overview of what some takeaways from study 2. Lesbian, gay, and bisexual people experience broad health disparities, and laws in a given jurisdiction provide protection or limit protection for LGBT people. And we viewed those laws as a proxy for the social environment for LGBT people in that jurisdiction. So to explore that, in this study 2 that we discussed in our manuscript, we conducted a study of state and county level policies focused on LGBT populations as of 2014. So again, using a multidisciplinary approach and using proxies of sort of legal domains that we wanted to focus on, we developed a policy data set to facilitate analysis of associations between policies that protect LGBT populations and outcomes, health outcomes for those populations, particularly for STDs. We again used policy surveillance methods to identify and categorize those protections across several legal domains, including employment, same-sex relationship recognition, and housing, among others. And we determined some proxy measures to focus on within each domain. Our assessment found substantial variability in state laws that address formal protection for LGBT persons among public and private employers, as well as in housing practices and for public accommodations. The largest percentage of states with protections was typically in the Northeast, followed by the West. We found fewer local laws that focused on protections for LGBT populations. Our team's research scientists used policy data from that assessment from counties in the top 30 metropolitan statistical areas in the US by population to calculate quantitative indices. Indices were measured overall and for each legal domain to develop proxy measures for the social environment related to LGBT people. in each jurisdiction. And then this slide goes into a little bit more detail about how we used the indices. So in short, we assigned each legal domain a composite protection score out of 100 for each county based on the presence of legal protections in that domain, the state and or the county policy in each jurisdiction, and weights that we based on empirical evidence of the association between that domain and the aims of our study. So for example, we heavily weighted legal domains found in peer-reviewed literature to be strongly linked to HIV and STD risk among LGBT populations, like relationship recognition, which was more heavily weighted. So through our use of weights, the index linked the findings of the assessment to STD and HIV prevention risk and disparities that were already identified in the scientific literature. So this slide just gives an example of how the legal domains were scored in each jurisdiction. Here you see some counties in California to come up with a composite score for each state, as well as for each of the 282 counties and 165 cities that we studied. So now I'm going to get into some of the lessons that we learned throughout both of these studies that we highlighted in our manuscript. We saw time and again that our multidisciplinary teams provided a mix of unique skill sets that had clearly enriched each component of our studies. In this table, which is pulled directly from our manuscript, we indicate the specific ways that our team members contributed distinct skills and methods to our study components. So scientists and public health researchers on our team had the expertise to develop new measures like the indices and to conduct qualitative research, while our attorneys helped the scientists to recognize gaps in policies, to understand the relationship between state and local policies, such as preemption, and to identify qualitative interview participants. Content experts that we tapped from related fields provided specialized expertise to help us hone in on our research questions, to help us develop our study instruments, and to help us with our analyses as needed. So this is just the second half of our table here to highlight that the scientists that were well versed in literature relevant to the research, whereas as the attorneys, we had the skills and understanding to find and interpret relevant policies. And this combination of skills really improved our components. Some of the folks on our team actually have experience in both legal research and quantitative and qualitative research, which just bolstered the overall strengths of our team. Tapping into our various disciplines and methodologies also helped us address gaps in our studies and to assess the potential effect of policies on rates of STDs and STD disparities more directly than we would have if we didn't have those different perspectives on the team. So for example, in study 1 of criminal justice involved populations, the policy assessment yielded a large amount of information about the consequences of drug possession, including the loss of eligibility for essential public health or for essential public services like public assistance and housing. Whereas the qualitative study helped us fill in gaps about healthcare access and STD testing when folks are incarcerated, which is information that we wouldn't have been able to find in statutes and regulations, but is more directly tied to STD rates. In study 2, an example of how this worked is that our policy assessment provided us with a very rich data set on state and local LGB policies, and the development of the indices made the data more useful for others to directly examine the relationship between policies and outcomes such as STD rates, and to take and use our indices and weigh them differently if they wanted to do so for their own research purposes. Some limitations that we recognize are that, especially in the methods we chose, are that policy surveillance often leverages federalism's natural experiment by analyzing policy variation across jurisdictions that each have their own sets of laws, but falling under that federal system. But many key social determinants of health really vary within states or are steady across state lines, and then people are governed by local ordinances in addition to federal and state law. So including multiple geographic parameters, so the federal, state, and the local level, can really address certain limitations that are inherent if you're only doing a 50-state legal study. Some limitations with qualitative research. Qualitative research is incredibly valuable for exploring how laws are actually perceived and experienced and how that experience may vary across jurisdictions and communities. but it's typically not generalizable or representative, so the scope of your findings is geographically and sometimes demographically limited. It also comes along with sometimes unavoidable and time-consuming hurdles like struggles in identifying and recruiting eligible participants in the study. And I think these next couple slides are really the key of what we wanted to be the takeaways of our manuscript, which are the considerations when you are embarking on this multidisciplinary mixed methods approach to studying health disparities. Some of the important considerations we've learned to address as early and as comprehensively as possible are sort of overviewed on this slide. So due to variations among a team in educational training, subject matter expertise, and skills, we as collaborators are often not always speaking the same language, and we really may be unfamiliar with each other's methods. So on our team, the attorneys were not always largely familiar with developing instruments for human subjects research, but the research scientists were not always well versed in, for example, policy surveillance methods. So our experience demonstrated the usefulness of overcoming these challenges in order to effectively wield the power of our approaches. So we suggest familiarizing with each other's methodology rather than defaulting to each person working independently and then coming together at the end, and really doing that at the forefront of the work. Also, identifying gaps in each other's methods will help figure out where another method can come in and address those gaps and really complete a full picture for your study. Also, recognizing sometimes when you don't have the full team and you only need a little piece to plug in, figuring that out early on and bringing in some subject matter experts to just like plug into small pieces can be really helpful as well. It's also really crucial to establish a study foundation by collaboratively identifying the study scope, engaging in preliminary research together, and allowing the process to be iterative to align and refine your methods and define the scope over time before expanding to your full study population. So all of this was key to success in our studies. So really, we just found that using these mixed methods and multidisciplinary approaches strengthened our assessments for studying populations that increased STD disparities and risk. And we hope that these approaches and this advice can really help other stakeholders who are trying to do similar work, potentially addressing other types of disparities and their relationship with policy. So since policies don't exist in a vacuum, neither should our research or our research team members. Public health, as we know, is influenced by a variety of social, behavioral, biological, structural, and other factors, and teams that include various disciplines and perspectives are much better equipped to explore solutions to improve public health. So that's what I was hoping to cover today. Thank you again for your time. And if you have any questions or want to hear more about our studies or what we've learned from this type of work, we'd love to talk to you. Please reach out. Thank you.
Thank you, Kelly. And now we are, if you do have questions, here's the screen showing you how you can enter your questions into the, simply click on the Q&A button at the bottom of your screen and you can type them into the pop-up box. While people are having an opportunity to enter questions, I thought I would get our conversation started by offering some questions to Marcelo and Kelly to start us off. So first, this is a question for Kelly. As we hear calls for reinvestment in public health infrastructure and working to achieve greater health equity, what do you see as the most critical areas to apply a mixed methods and multidisciplinary approach?
So I think the opportunities are really endless right now, as we can, I'm sure everyone on this call can think of something that they would feel is critical right now. And I think all of those answers would be legitimate. There's just so much that's ripe for studying right now, and so many disparities and inequities that have really been laid bare by everything we're experiencing with the pandemic. When I was reflecting on this, something that I thought about that I think could make a big impact in terms of getting, in terms of making connections that really can no longer be ignored, would be looking into the effects that we're seeing now with community policing approaches and better studying what that's doing in the US. I think there's a lot of one-off or small studies on this in other areas of the world. And then in the US, we have more limited data to show that this actually really does work and to support that cause. And I think coming together with different disciplines as a really effective de-investment in law enforcement and reinvestment in social services and communities is going to require a lot of people at the table and a lot of data, I think, to make sure that folks are listening and understand that this is very documented and can be very successful. So that's something I was reflecting on, but certainly there's many things that are right for a multidisciplinary mixed methods approach right now.
Great, thanks so much, Kelly. Marcelo, when thinking about where your paper in the SSP laws and the changing landscape, what do you think has led to the fairly large increase in state jurisdictions where syringe services programs are now enabled to operate legally?
It's a really good question with a maybe not satisfying answer. I really don't know. So I think the way to figure that out would be to try to look at things like legislative history. And as Kelly mentioned, sometimes this is bigger than public health and bigger than law. It's about social context. It's about really understanding what's going on culturally. So there's lots of changes that may have influenced that. I would hope that some of the publications that we built our own paper on that really talked about hotspots or talked about states that were high risk for HIV outbreaks or Hep C outbreaks in rural states or southern states or Midwestern states, that type of publication would influence policymaking, but I can't say that that's what happened. But I do hope that, you know, as we continue to publish on things, that this highlights where there are problem areas and where there is opportunity for improvement. But I also would hope that, you know, that future projects would also focus more upstream and start to figure out what are the drivers to policy change and what's happening in the community to actually drive these types of changes to expand access to SSDs, for example. So yeah, great question, and don't really know the answer, but hoping future research can illuminate that.
That's great. Thanks so much. And I have a question for you both. Kind of, we take a step back and are cognizant of the time that we are living in right now with the COVID-19 response. And I wonder, Marcelo, and speaking specifically about some of the harm reduction work of which SSPs are, but what lessons from the implementation of harm reduction programs and policies are applicable to the efforts to mitigate harm related to COVID-19 pandemic? And how do you think those lessons can most effectively applied to trying to address the overwhelming COVID-19 disparities that we are seeing throughout the country?
Yeah, so another great question. So I think something that we've learned about SSPs and harm reduction organizations in general is that they have always been a huge partner in the community. So whether it's the HIV epidemic we're talking about, whether it's Hep C, whether it's the opioid epidemic, or whether it's smaller outbreaks like here in Philadelphia, we've had Hep A outbreaks in the people who inject drugs community. SSPs have always been ready to, I guess, step up and really connect to a community that's not always easy to reach out to via traditional public health methods. So I think COVID is the same. They could be, SSPs could be a great partner in terms of like advancing COVID messaging and also getting information out to hard to reach communities. So yeah, I think the big lesson is that there is a willing and able partner out there that could really advance a lot of public health in general. And as I mentioned, you know, in some ways, we're doing a disservice to SSPs by just labeling them as SSPs. They are actually healthcare organizations that provide a broad range of services to the community. And COVID is no exception. They could be a great partner there. And I know a lot of great COVID work is happening around the country through SSPs and other harm reduction organizations.
Great. Kelly, would you like to add anything about what you see as kind of some of the application of some of this work around COVID-19 and addressing the disparities there?
So I think kind of building off of my previous answer, I think it's in some ways an exciting time for this kind of research because there is so much that previously folks who aren't engaged in public health saw as really disconnected, that folks in public health and who have been in public health for a long time have always seen as very intimately connected, but haven't had a real way to properly get that across, I guess. And now with the pandemic, I think you'd really have to be living somewhere where you never see the news to think that like some of these things that we didn't see as a community are connected or really are. So I think now is a really ripe time to be making those connections for folks through our research, and also to be taking things that we've already learned and already is well researched and getting it out there better. I think so much of what we know lives sort of in the papers, and I guess we're all a little bit guilty of that. We're here on this webinar kind of doing that, but like the hope, I guess, and our team of co-authors is always thinking about this responsibility of, you know, how do we take it to that next level and make sure that what we've already done and that we've already shown through data and through making these correlations can actually be put into practice. And I think a silver lining of the just the crushing things happening with the pandemic is that there isn't time anymore to kind of sit around. And so people are more open to doing things based on data that they might have dismissed or not been as wanted to sort of take more time on, or now recognizing the time is now to make changes and really implement what we've learned from policy research. So yeah, I guess that was my long-winded way of saying I think the time's right for a lot of the things we've already done to really be put into, taken into consideration for the practice.
That's great, Kelly. Thanks so much. And I just want to remind the audience that please feel free to go into the question and answer box and enter a question for our panelists and engage in our conversation. Marcelo, building off of Kelly's response there, I wonder if you could tell the audience a little bit about what you see as the impact of policy research or research evaluating policies on reducing disparities and improving health outcomes.
Yeah, so I think the issue with policy and law as a solution to problems is that a lot of the time, you know, we'll see a problem out in the community, there will be advocacy around it, and then the solution is often seen as passing a piece of legislation or changing a policy or something like that. And then largely people tend to forget about it. They think the problem's solved, but we all know that that's not true. Problems continue to evolve, the circumstances change, and healthcare is especially complicated, and public health is especially complicated. So what things like policy evaluation or policy research or policy surveillance or whatever you want to call it, what that does is really allows us to keep track of what the policy changed and to see what impact it's having, and allows us to tweak policy as an intervention, and really allows us to continue to advance policy and solutions as the problem continues to change and evolve for so many different reasons. So that's really the value there. It stops us from like walking away at the end of the day and then coming back 10 years later and saying, oh my God, we created a whole new set of problems when we passed this law. It allows us to stay on top of, you know, the impact that a law is having immediately, and it allows us to track it over time as well. So.
That's great. Thanks so much. And I'm going to turn back towards a little bit more specifically to the papers that you all presented about. And Marcelo, I'll start with you. What evaluation of the impact of surrender services laws do you think are most critical to conduct now, now and in the near future, as we watch this growth that has happened and we want to see how that can be sustained?
Yeah, so that's a little outside my wheelhouse. So I'm hoping somebody else can pick up where we started. What I see this paper doing and the resources that we create at the center doing is really creating like a lay of the land of like where laws are today. And then I'm hoping people who do policy evaluation or that kind of work can pick up where we left off and actually figure out with all these different types of legal structures that exist in all of these states, figuring out what type of impact this is having on various epidemics. So really, I think the type of work that needs to happen is connecting the law and policy to the public health impacts. And there's so many different aspects of this we could look at. So we could look at, you know, how harm reduction organizations and the availability of SSPs are, you know, impacting COVID, or we could look at HIV or hepatitis C or the opioid epidemic. So really, it's about somebody making that connection. So really, where I see my role in the work of our center is really just creating the foundation of like sorting through all the laws and like digging through everything and like simplifying it in a way where an evaluator could pick up and really tie that to public health impact. So I think that's what needs to happen, just that connection to real public health as opposed to just pure policy research.
Great, thanks so much. And Kelly, when you think about, for a researcher who wants to apply a mixed method approach, who has not done this work previously, what tips would you offer them on as they develop their team and their research plan?
So I think, at least in our experience with our team, like I mentioned, we've been working together for over 5 years now on 4 large studies, only 2 of which we were able to highlight in the manuscript. Something that we've learned is team member rapport does matter, and also really, really frequent and open communication matters a lot as well. So in all of our studies, we've spent a lot of time in the very beginning sort of recognizing what each other does, talking a lot about our different backgrounds and what we're bringing to the research, like what is most interesting to us about the research questions and how do we think it should go, and making sure that we're all kind of on the same page with that from the beginning. And then also spending a lot of time at the beginning scoping the projects so that we don't end up, 6 months down the line recognizing that we went off in one direction that's not actually getting us to the objective that we had, which is really easy to do when you're talking about these complex areas of laws that are very indirectly related to the outcomes that we want to study. So you have to kind of keep those threads going the whole way through, or it's really easy to get on a different track. There's just so much that you can look into. So thinking about how you want to communicate early on, we would always have regular meetings, sometimes as often as weekly for the first, a couple months of a project to get it going. Was really important for us. We also would convene for a day or 2 in person at the beginning of studies, even if we were in different places. Now, of course, times are changing, but you can still do it in other virtual ways. But taking aside sort of dedicated space and time that's different than your normal workday to really sit down and think about what you're going to do together, those sort of early framing conversations and scoping conversations really have made a huge difference for our success. So I think communication and level setting and scoping together is probably one of the biggest pieces of obtaining success in these kind of studies, where you're sort of all coming from different areas, different methodologies, and different styles of working.
Thank you so much. We have time for probably just about one more question or so before we end up wrapping up today. If there are any questions, please feel free to put them into the Q&A box. And I wanted to come back to you, Marcelo, and thinking about it, as your paper highlights, is that there are a lot of complexities to laws around authorizing syringe service programs and the services that go with those syringe services programs, which poses potentially a lot of challenges for how to evaluate the effectiveness of those laws and what their impact is. What challenges might you see that there are because of the great variety of the laws across state jurisdictions, and how do you recommend that we overcome those challenges if we're trying to, over time, be able to demonstrate what the health impact is of syringe services programs throughout the country?
Yeah, that's a great question. I don't know if I have a full answer, but what I think would be difficult from the evaluation perspective is that so much great work is happening, across all of these different epidemics, whether it's HIV or Hep C or opioid or whatever it may be, that I think teasing out what the law is impacting versus like what other types of policy or other types of like guidance or, programs or different types of initiatives, how all of those different things are impacting the epidemic. I imagine that teasing that out and figuring out what the law is directly impacting would be one of the larger challenges. In terms of suggestions of how to analyze that, I really don't know. I think probably starting small would probably be a good way to look at it, like within certain states, or even there are some jurisdictions in which SSPs have been authorized locally, including our own Philadelphia. So even analyzing at a smaller level and trying to figure out how policy is directly impacting the epidemics at those types of levels, I think would be a way to do that. But there's really just so much great work going on that I really think teasing out what level of policy is actually causing the decrease in cases would be a major challenge. I think you're still muted.
Good. Okay, thank you. Just to wrap us up, Kelly, when we think about, I know all of us want to make sure that any research that is done and put into these publications like the PHR supplement are not left on the shelf and are put into action and applied to improve health for people that are in our communities. What might you recommend to researchers about how to best engage stakeholders to ensure that information and the results of studies are applied for action? And that'll be our last question for this afternoon. Thanks.
Yeah, so I'll be brief. So I think our team is always thinking of better ways to do this ourselves, sort of challenging ourselves on this as well. We do always start with trying to, start with peer-reviewed research and literature and then go from there. So we try to get things published so that we can then move on other ways of getting the information out there and bringing people to the table. And I think just thinking about venues is important. So some things really can be digested and put out in a social media campaign with different key takeaways that can be implemented. That's sometimes the best way to reach communities. Sometimes I think the best way is through funding follow-up work that isn't in the research side, but really goes into implementation and sort of fielding the ideas that we've come across with communities and people who are going to be impacted and seeing how they feel about it and what they think would be the best way for it to be rolled out. Sort of continuing, I guess, with qualitative research, but really with an eye towards implementation so that what we're suggesting can be successful as soon as it hits the ground running, rather than sort of like Marcelo was saying, doing something sort of hastily and then not really thinking about what the later outcomes are going to be. I think that can be prevented really with some thoughtful follow-up funded work to just take the results into action. So maybe that's a call to both the people who are funding this type of work and also doing the work to think about that collaboratively as well. But yeah, I think thinking and really building in dissemination into these research studies from the get-go. So thinking about how the last couple months or something of this study is going to be spent on thinking about thoughtful dissemination so that we can get the word out there in different ways that reach the right people and the right stakeholders. I think that's a way to really build it in right from the get-go as well.
That's great. And thank you both. I want to thank Marcelo and Kelly for their time and expertise and dedication to studying the use of policy as a tool to save lives and improve health outcomes. We also want to thank ASPPH for putting this webinar together and making it available. And here is a great screenshot where you can find the full special issue of the journal at Public Health Reports. With that, I want to thank you all for joining us today. It's been a pleasure to be able to bring this information to you. Thank you so much.
Thank you.
Thank you.